Good afternoon and welcome to Incorporating Social Determinants into the Patient Picture for Superior Population Health, a webinar tweet chat combo from HealthSystemCIO.com, sponsored by Optimum Healthcare IT and Clearsense. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the Editor-in-Chief of HealthSystemCIO.com, and I will be your moderator today. We are having a simultaneous tweet chat hosted by Kate Gamble, our Managing Editor and Director of Social Media. You can participate in a separate browser or on your phone by using the hashtag HSCIOchat, or you can view the tweet chat in the Media Viewer panel on the right-hand side of your screen. We're also going to use the Q&A panel today. We hope you'll have questions. You can go ahead and send them in as they occur to you in the Q&A box in the right-hand side of your screen. Leave the default set to all panelists. I'll take a look at those and we'll be posing them later in the program. Then you can download the deck using the URL on your screen. It's at the bottom of some of our slides, and it will also be sent out in the chat box, so you can get a hold of that. Just so you see how we're going to spend our time today, we're going to go about 30 minutes first with Dr. Shafiq Rab, SVP and CIO at Rush University Medical Center. And then we're going to hear from Toni Jarrett, Executive Director of Optimum HIT, one of our sponsors today. And then we're going to have our Q&A. So without further delay, I'm going to turn it over to our good friend, Dr. Shafiq Rab. Dr. Rab, thanks so much for joining us.
Toni, thank you for having me again. And thank you to Optimum Health, and thank you to all the friends who are listening. I came to Chicago about 7 months ago, and I have to tell you that the people of Chicago and the community of Chicago is changing me by the minute. As I go through my presentation, the idea behind it is to share how I am changing as a CIO and how things are getting better here over the years and months and times that I will spend. But most importantly, how we are understanding healthcare in a different way and how technology is allowing us to do things better. And more so is that whatever I have learned all my life, I just found out that I have a lot to learn. So as I'm moving forward with my presentation, I always present this slide of care continuum. And we talk about care continuum and we talk about the last mile, which can extend into home. And home, as I call it, home care is the best care. Because if you are at home, that means you are healthy and you are enjoying your life and you are not utilizing any of the resources of healthcare, whether it's a hospital or whether it's a clinic or whether it's a rehab or whether it's a gym or any other place that you have to go. Unfortunately, if you don't have a home, then that makes it a little bit more difficult, that otherwise known as homeless. And in the city of Chicago, there's a whole homeless information system that I became aware of. And as I would proceed with my presentation, I will also tell you that as I'm learning, what this has enabled me to do is that as I'm understanding it and as I have been successful in doing things for the people who have nobody, that means people who are homeless, as compared to people who have home, that you might be hearing a train in the background because my office is next to a train station, that we will use the same methodology in taking care of people who have and taking the care into the homes. Next slide shows you about the sentence that I say is the care continuum has now changed from care in the big hospitals to care where you are. And people are now demanding how and when you want it. That means for the normal ailment, not normal, small things like UTI, upper respiratory tract infection, small things, people want that convenience from where they are instead of visiting in a car and going to a long place or a distance place and then getting into that care situation. As we go through this continuum, I have to explain something about Rush. So Rush University Medical Center is a university, also has a hospital and 2 other community hospitals at this time, and multiple outpatient locations. So there is a continuum of care that happens here, which also includes not only ambulatory care, but also ACOs and other things in which we take care of people in our continuum. As we are going forward with that, what has happened, we are finding that care does not only belong to the institution, but we also found out that there is a whole group of people who can't have an access to care. And as we are finding that out, we also found out that there are other needs that determine the care. And some people have coined that as social determinants of care. So as I'm getting into it, I will talk a little bit more about the last mile. That means people who are homeless and people who have no place to live, or are the poorest of the poor. For them, care is important, medication is important, but more important than that is their lodging, where they will live, or when they will eat a meal, or when whether they have clothes. If it's a winter season, do they have warm jackets or not? Those become more important than taking a drug, than taking a medication. So as we are understanding that, shelter, food, lodging, and language becomes more important in determining their health, as well as whether they will live or die. So Chicago started teaching me that. And as a CIO, as a person who's involved in this, I'm trying to understand that, and I coined a phrase, taking care of citizens, not subscribers. Subscribers are people who have insurance and they subscribe to certain things. And Rush, we think that the entire Chicagoland are our customers and our needy people. So I'm walking through a frame of mind in which visit to the ED with a drug is not the only thing that helps people to make their lives better. Now, if you don't talk about the homeless people and you talk about other caregivers, we find out that medication adherence, understanding that they have to take the drug, understanding that they have to exercise, understanding that they have to wake up and move around, understanding that they have to have wellness, understanding that they have to talk to a human being, understanding that the environment plays a role. These are all different social determinants that makes a person healthier quicker, that allows person to live longer. In Chicago, where my main hospital is, that is Rush University Medical Center, people who live on the west side of my hospital, as compared to the people who live on the east side of the hospital, their lives are ended 16 years earlier. Think about the social inequities that we are facing in this world. In the social determinant of healthcare screening, as I'm talking about it, so what we did at our university, we have an electronic health record. And in the electronic health record, we put certain things, which is like clinical documentation. But we did not have a way of connecting it to the social needs. So we went and made friends with a company known as NowPow, which is run by Rebecca Kohler. She's the CEO, and most of you know the name Kohler, where it came from. And what that does, it allows us to connect our needs, our social needs, to a social software that has social presence in the community, at the same time is also connected to donors and other people who feed into it. That means people who donate money, people who donate lodging, people who donate clothing, and also the Chicago's a homeless information system can be connected to it. That means where the shelter is, where the person can live. So we embarked upon connecting our software to them. As we were doing that, we found out that we ran into certain problems. But as you know, Chicago is teaching us, and we are learning, and I am learning, and my team is learning. So of course, all possibilities happen when you have a heart and when you have a feeling that you are supposed to help people. So what we did is that we took and we started using FHIR, Fast Healthcare Interoperability Resources. And by that, using that mechanism, we were able to not only connect the ADT, but there is a resource that allows us to understand the documentation of the social needs. So we use that, and we used, now we are working with Epic, and Epic has helped us to do the CDS hookup, which is the continuation document, so that we can transfer data from our EHR into the NowPow with the social screening. And what the social screening does, it does social referrals to a range of community resources like food banks, like transportation, like housing, and that empowers the social workers because they're tightly integrated with the electronic record of RUSH. So what that means, let me walk you through what that means. I'll go to my next slide, but I'm going to walk you through as well what that really means. What that means, when a patient comes to RUSH, the social worker or the doctor at RUSH can now prescribe a drug, can prescribe clothing, can prescribe lodging, can prescribe food to that individual that goes from the electronic health record here into the NowPow, which has now social referrals to the community, different types of community resources, which can now go from NowPow back to Epic, from Epic into MyChart, and into the cell phone of the recipient. So they get a text, they can get a message. In Illinois, they do provide cell phones to the homeless people because it's part of their security and living. So now they have an immediate solution, so they can get their behavioral health care needs, they can get their clothing needs, they can get their lodging needs, which is more important than taking the drugs. So it is now available today. With the help of another company known as Higgy, what we have done is that we have put two machines, the same kind when you go to a pharmacy where you can take your blood pressure, in the community where the blood pressure is taken, and that blood pressure, height, weight, blood pressure, goes back into the electronic health record. So what we are doing is that we are trying to prevent CVA, which is cerebrovascular accident. Imagine you have no money, you are poor, you're homeless, or you're on Medicaid, and yet you get a stroke. All of a sudden, you are the only earning member of your family, and you can't provide not only the health care, now you can't even provide food. So what that does now, that we have now incorporated social determinants, we have incorporated blood pressure, and now we are incorporating that in our community. So we are closing the loop. As the patient arrives or consumes the prescribed services, NowPow API notifies the RUSH EHR, closing the loop. If the patient does not consume a service, social workers may nudge the patient via text or email reminders and communication so that they can go get their services. Most important is that we are tying it to the homeless information system to ID the homeless people also. So Illinois and Chicago has a whole homeless information system that allows people in the olden days, but they have to do now, which is only about 2 weeks ago, they have to put things on a piece of paper and then put it into the system. So what we are doing now, by providing this tie-in, it allows us to identify who is homeless. On top of it, in future, what we are doing is that we're also collaborating with the other 4 EDs in our area in the hospital so that we can coordinate care. One of the things that we found out when I came to Chicago, there are a lot of good people here. There's a lot of good work going here. I'm not the only one who's doing good work. There's a lot of community great work is being done. The only thing that is not happening is the coordination of that care. That means we have a diabetic clinic, we have a diabetic education clinic, we have a diabetic rehab clinic, but the 3 of them are not talking. By connecting that dot, by connecting that using FHIR and the APIs, and by connecting them to the referral system, we are now embarking upon connecting people so that the care can be coordinated. That is the next thing that's happening with us by doing this. And on top of it, we're getting the analytics for improving the health of our population. We're identifying lack of critical resources of services. That means we are finding out that within those communities, there are health deserts. What that means, pharmacies used to be there, they're not there anymore. The bus route used to be there, the bus route is not there anymore. So this coordinated effort is now helping us to find new ways of gaps, and what we are doing now is that we are coordinating those gaps. And on top of that, imagine this, Anthony, my friend, that if you prevent one CVA to come back to the ED, there is a cost saving for the hospital, but better cost saving is for that community, that there's an able person who can work and make a living in a respectful way. And we are also correlating specific diseases and appropriate precision treatments. And we are now tracking and improving outcomes. So in short, what I'm trying to say here is the following. By taking our electronic health record and connecting it to a social welfare software and connecting that to the homeless information system and connecting that to other community health services, we are all of a sudden embarking upon a new way of understanding how healthcare is delivered and how the resources are being utilized, and we are also helping people to understand how we can bring coordination of care in a population that does not have anybody to take care of it. So this is what we are doing at Rush nowadays, knowing as the social determinants. And of course, now we have statistics which we are gathering to prove to the people that by improving lodging, by improving, we are now providing about 400 meals a week, by improving food, by improving clothing, by improving medication adherence, and by allowing blood pressure to be taken in the community, and by making sure that the clinical care is now coordinated with social care, the overall health of the community may or may not improve. Lastly, what I want to add, what we are also doing on top of that in our community, and I want to let people know how we are doing things. We also have a special relationship with 2 schools in the community. And what we are doing is that we have taken 200 interns from the community and brought it to Rush. I took 22 of those interns in IAS. We taught them the basic IT and also got them certified in certain software, otherwise known as Epic, which allows them to become credential trainers. So all of a sudden, they have a new way of making money. That means they can go and become a credential trainer and make a higher income. At the same time, all those 22 students that I took for the last 1 year, we from IT went and taught them information technology as a part of their curriculum. All 22 of them got into a college this year after they graduated. So we are not only looking at the social determinants, but as an institution, we are collaborating with 122 other entities in Chicago. We call it the Westside Collaborative, and Rush itself is one of the anchors and put in $6 million towards that so that we improve the mobility, the security, the financial ability of the community. But from our side, from the IS side, which other institutions are also now looking forward from us to learn how to do that API connection into social determinant softwares like NowPow and others, so they can understand it. And there are other institutions in Minnesota, like Hennepin County, up in New York, are reaching out to us to understand how we can do this again. And of course, anybody who's listening would like to know how to do it. As always, I'm ready to share that. And back to you, Anthony.
All right, very good, Dr. Rab. Thank you so much for the presentation, and we're looking forward to the Q&A. So I want to encourage folks to send in questions, and we will get to those. There's a little contact information for Dr. Rab, so you can jot that down or get a hold of it in the deck. So before we do get to our Q&A, we're going to hear from our next speaker. Toni Jarrett is with Optimum Healthcare IT, which is one of our sponsors today, along with sister company Clearsense. Toni, let me get the control over to you, and we're going to thank you for joining us today. Just give me one moment. All right, Toni, go ahead.
Hello, everybody. My name is Toni Jarrett. I'm an Executive Director of Advisory Services for Optimum Healthcare IT. First of all, thank you. We are glad to be one of today's sponsors, and we just got a few slides of information just about our organization. We are a full-service and growing healthcare technology company. We're based in Jacksonville, Florida. However, we have team members and support clients all over the U.S., Europe, Australia. We were rated #1 in class for 2017 for enterprise implementation leadership, as well as a couple of subcategories. We're very proud of that. Again, we support all of the areas of EHR and ERP and technology solutions. There we go. We do have 9 active service lines. We provide those in the areas of advisory, implementation, security, training and activation, global services, Epic's Community Connect approach. We also provide overall services for EHR and ERP solutions, including PulseLive managed services for application support and maintenance, for analytics, and for specialized services such as lab and other ancillary programs. While these are larger kind of enterprise cross-functional service lines, we do provide solutions in many different ways. We do enterprise technology for advisory and full-level consulting. We provide staff augmentation. We do legacy support, full-scale training and change management, as well as some of the programs today to support population health, regulatory compliance, data solutions, analytics, legacy decommissioning, and other services. We're very proud of our class recognition with 2017 and Best in Class overall IT services, as well as some of the subcategories, and have just provided some information here for those accolades, as well as how we compare against our major competitors. And finally, I've just provided some contact information here for myself, as well as a few other key leaders and executives in our organization. And again, we are happy to be one of the sponsors today and appreciate the time.
All right, very good, Toni. Well, thank you for joining us today and sponsoring, and we're looking forward to our Q&A. So once again, send in your questions in the Q&A box and leave the default set to all panelists. Let's start with our first question. Dr. Rab, what was the technology investment your community resource partners had to make in order to be compatible for a fire referral environment?
So here's the thing is that our partners did not have to spend any money. They did have some HL7 capabilities, and they were working with a company from in Madison, Wisconsin. But for the fire capabilities, we did all the work. Here's the thing about fire. It's not that hard. I mean, that's the part nobody understands. It's so simple, and all the resources are already there. So the answer in short, nothing.
All right, very good. Next question, what social?
Anthony,
yeah, go ahead.
If you want to know, the fire shell is from .NET. Furor, which is a shell available from Holland. This is a fire. I can spell it for you. It's .shell.net FHROWE. You take that directly from there and use that SDK.
Okay. All right. Very good. Next question. What social and complex needs assessment tool is Rush using to identify referrals to send to NowPow? There are a number of screening tools and frameworks available. Let me know if you need me to reread that, Dr. Rab.
In Chicago, there's a consortium here that develops a social tool. It's a homegrown that we use 2-3 of them. I'm not a social worker and I'm not good at it, but I do know that I wish I had asked one of the social workers for us to join on this meeting. But what I know of is that it's our own homegrown, and but they do use 2-3 standard ones, and they did develop one. I can text somebody while we are having this question and actually get that information later to you, and you can publish it.
Okay, very good. Next question, what type of metrics are available to measure performance, outcomes, and or results of the SDOH-based referrals?
I thought that was going to happen. Yeah, because here's the thing, man. I just wanted to let people know we're doing it. So we are still in the phase of developing that. Here's what our thought is, and if the person who asked the question, if he or she has some, they can give us some. But I'm going to tell you a couple of things that we have. One, we are doing at some of the things we are thinking about as most referred services. That means summary of key metrics of referred service providers, historical view of number of referrals by client attribute, summary of key referral metrics over time, summary of key closed loop referral outcomes, how many we referred, view of clients served by condition and organization creating health RX. We call it ERX here because that's the terminology that was coined. We're also looking at by like, for example, awareness of condition. For that, we are using view of clients served by client profile and organization creating health RX. Also for engagement mode, we're looking historical view of nudges by client profile and mode sent. For engagement summary, we're looking at summary of client interaction per client averages. For executive summary averages, we're looking view on number of clients receiving health RX by client profile, condition, zip code, and user level. For executive summary engagement, we're looking at summary of client interaction per client averages. So service types, we are looking at summary of service types provided on health REX. Service gap distance, we're looking at rate of resources per 1,000 needs for service type by distance. You know, for example, we're looking at how long did they have to travel to get food, you know, because that's one of the indicators that suppose they have to travel 5 miles. One of the things we are doing here is that we're taking the organic food and we are distributing that at a lower cost and price. So summary of service providers nudge to clients. So there are about, say, about 50 to 100 different parameters that we are looking at so as to better understand, in summary, what we are trying to understand, how many people we served, how many lives we saved, what is the distance that people have to travel, and how many times we had to go and encourage people to actually receive it, and then how many people actually receive the help, and then we're looking at how many people actually decrease the resource utilization of the main hospital or main places. So that's how we are determining the SDOH. So thanks for asking that question. I love the person who asked that question. It's a very in-depth question. I hope I answered in depth.
All right, I think so. The next question is similar, but let me know if you want to add anything. How long have you been using this collaboration, and how are you measuring your success?
So the success for the day, so most people who know me, I'm not a person who's involved in becoming a hero or some kind of an important person. That's not important to me. But what's important here is that we were successful in proving that we can use FHIR to connect to any software in the world. Anybody can do it. So that was the first success of the IS team. We didn't even have FHIR server when I came here, just to let you know that. So we built that in about 6 weeks' time. So the way we are measuring success is that how many clients we have reached, how many referrals we have made, and how many referrals have been fulfilled. We went live, I think, end of July, or sometime in the middle of July. So this has been less than a month. And I had given Anthony this date, thinking that maybe we'll go live today. So it's been only a month, but the buzz that has happened because of that when people learn about this, watch this, man. There is a Franciscan house here where people get care, right? So here's what it is. You give care, but there's no connectivity there. So what did we do? We went to a company like Comcast, Xfinity, and they said, okay, we'll provide you with the internet. So incremental work that allows just by IS thinking that we will connect. We just thought that, right? But what happened in return, that a community resource got connectivity. What happened in return, people got tablets. What happened in return, more people got referrals than they were getting before. So maybe in 3 to 4 months, when the number statistically becomes significant, we can publish that, or in 6 months' time, and say that by doing this, we increased the longevity by this. But it's a long time thing. You can't just say the impact happened over 1 day or 1 month. This thing takes 6 months to a year. But in numbers, we can say that we have increased the number of referrals. We have provided these many people food. We can say we have provided these many housing. But that does not change healthcare. That's just a number to make me feel better. That's not the outcome. The outcome is that we were able to manage a person's blood pressure so that the person did not end up in the ED for at least a year. So I think we have to wait for that.
All right, very good. Let me bring you in, Toni, for a moment here. Are you getting a lot of requests from clients on how they can start bringing these things into the EHR? Is that something you're hearing, and to what degree?
We are, and I think what we're seeing is at various levels based on where an organization is with the maturity of their EHR. I think as organizations continue to use their EHR solutions, they're looking for the next step and how do they use the data to make decisions for their patient population, for the services that they provide, for how to move services to preventive more than post-diagnosis, and use the data not just to take better care of the patient, but to provide a more service-oriented atmosphere for their patient population in the community. So I think it's not just data as Dr. Rab said, it's not just data within the EHR, it's having to pull pieces of data from multiple areas to then turn that into information that can be used.
Do you have any sort of basic advice from working with people on sort of first steps or things to do to prepare to have an environment where you can bring these things into play?
I do. I think, I think you attack this the same way that you would attack, the way you attack your EHR implementation or any kind of large-scale technology work is first understanding what it is you're trying to do and why you're doing it and who you want it to impact. So if you're looking at, creating a service mix within the organization that really represents the population of your community, or if you, want to look at how you can use real-time data to make clinical decisions or service decisions, even down to more tactical and, specific uses of the data for, reporting and things like that. I think it's understanding, again, what you want to do, why you're doing it, and who you want to impact. Then I think you look at kind of the tactical steps of making that happen. Where are you going to get the data? How are you going to pull it together? What are going to be your resources in storing that data and manipulating it to use it? So again, I think it's very kind of strategic level steps to understand vision and objectives, and then you get down just to the tactical of how you're going to get the information and how you're going to pull it out and use it.
Very good. All right, Dr. Rab, next question from the audience. Is Rush incorporating social determinants information, zip code, income, race, etc., to analytics other than community social medicine, such as using social determinant data points and integrating with KPIs such as CHF and other readmission risk DX?
That is such a brilliant question. So what we did is that we are not only, this is such a nice question, because people only think that we are only looking only on one aspect. This is an aspect that goes all over. So my CEO has told me and asked me, hey, why are you just asking only for the homeless and all those people? We should include it into the entire curriculum. Remember, we are a university, we teach here. So yes, the answer is yes. Rush is included now, started including in the entire population of the healthcare. We talk about food insecurity, we talk about utilities, we talk about transportation, we talk about housing instability, not only, because here's what it is. If somebody has a CHF and you want to really measure the person's efficacy, so disease does not come to a person by socioeconomic status. Anybody can have any disease, right? So the good thing is that we are now incorporating these things throughout our electronic health record and through our practice continuum, because sometimes the thing that is happening now, which is known as, I'll tell you an example, grandparent to grandparent, that means we are now facing a big group of people who are going into the geriatric age, and care is being provided at home. We need a new group of people to be trained and certified to take care of that. And that could be me, taking care of my mother who passed away, or somebody else's mother or grandmother. So in that place where you're giving home care, where you are measuring the person's height, weight, and you're measuring the person's ability to move, and you're also measuring whether they're getting the right kind of food, or you're also measuring whether the person can go to the clinic or not because their son is not home, or some people who can afford it, they can get an Uber ride. So these questions are pertinent to everybody. Thank you for asking that question.
Excellent. Next question, Dr. Rab, are other regions or medical centers using social parameters to your knowledge?
So to my knowledge, I think Hennepin County are phenomenal people. We learn a lot of social things from them. They are doing it. I think my friend Jack Wolf in Montefiore, he's interested in it. Yale New Haven is interested in it. some other people. So it's not like the ones that I know of, but other CIOs and other people are now seeing that, you see, in the olden days when we had waterborne diseases in the United States, people were getting cholera, dysentery. They did not go away till we did the social change of having pure water to drink and sanitation. This is the age of the fourth transformation. That means the next social change that has to come is not only care, the acute and chronic care, but also the social care. That means our happiness, our well-being, our other activity. So it is now being very heavily studied all over the United States, and other people are doing it. I may claim to be the first, but I'm not. There are other people who are doing it, and they might be doing it better than me.
Let's talk about dollars associated with this. You said the entities in the community did not have to spend any money, but as a health system, if you want to pursue this kind of agenda, do you need significant dollars to get it done? And is it difficult to attain those dollars because you're not able to demonstrate a hard ROI?
So if you really want to put that number dollars here, to incorporate all this from our EHR to the NowPow software, there is a minimum fees for NowPow because it's their EHR or social welfare EHR. So there must be some licensing for that. But if you add all the human hours on our side, this thing did not cost more than $19,000. That's pretty much it. So 19. It's not like, it's not like millions of dollars, not at all.
Okay, so it's not from a cost point of view, it's not a
it's
not
minimal,
a big issue.
Very minimal, very minimal.
Let's talk about the CIO's role. You mentioned you're not a social worker, but tell me about what individuals. Tell me what you think the CIO's role is in pursuing this kind of objective, and talk about the other individuals in the health system that they have to work with to move forward.
So you see, as you know, that our role is changing. Our biggest role as CIOs is to bring value, okay? And in value, there are a couple of types of value. First, we have to bring cloud, mobility, enhancement, interoperability, and we also have to find new ways of generating revenue. We also have to find new ways of decreasing expenses. So in this role, think what I did, what we did, my team did here, is that first we did interoperability by doing this project. That means we proved that interoperability is possible using Epic with a NowPow thing. We use FHIR, we use HL7, we use ADT, so that part got done. Second, we said, hey, we will prevent people from using unnecessary resources so that they can have the resources closer to their home or they can get it from somewhere. Now flip it. Flip this alert that goes to the homeless, flip this alert that goes to the Medicaid person to a wealthy person. Hey, you have not taken your medication. Hey, you have not done your exercise. So it's the same mechanism of alerting to the haves that you're alerting to the have-nots. That is the second thing that happened. Third thing that happened to this is that there is a need for all not-for-profit organizations to be part of their community. We have an ethical, moral, and all our mission vision statements say that. So that we have to do what we say, not just say it, we have to walk, and not only just talk. So that is the next aspect of the CIO, what you are doing. On top of that, when we are, as a CIO, now we're talking about using mobility. So automatically, if you're doing my chart and you're doing other things that allows the alert to go in the hand of the person who needs help in the poorest community, flip it, the nurses get it, flip it, the people who are the have, they can also get the mobility. You see what I'm saying? So what I'm trying to tell you is that by doing this small project, we also brought flip side value on the other side. Now the people that we had to talk to about is that we had to talk to our social workers, our community health workers, also understand how the the health actually works. So I had to go walk and go find out things and talk to the people. Also, we are lucky that we have David Ansel here. Dr. David Ansel is a known entity in the world of social work, and in Chicago, he has spent the last 40 years, and he's an inspiration for us. Plus, we're also lucky that Rebecca Kohler lives in Chicago, so that also helped us to understand what software we can use. Her software name is NowPow. And of course, everybody said nothing can happen for 22 years or 2 years or 5 years. We did it very quickly because we brought in Epic. We also brought in our own people. So what that means is that we also gave a reason for our team to feel good. So I esteem also that they have done some good work. Also, so it allows us to build a cohesive team. So they have worked for a purpose. They have worked for a cause. So as a CIO, I get to also motivate my team. I didn't have to do anything. My team got motivated, just excited by doing this. And they also learned how to coordinate between one type of team with the other team. These are all byproducts of doing one project. How do you like that?
That's a darn good answer. We just have a few more minutes left. Toni, I want to give you the last word. Any thoughts on executive leadership in this? Can the CIO drive it? Do they need to have someone else driving it and then they support it? You know, we always hear talk about executive sponsorship being important to a project, especially one like this that's got such a big social, clinical aspect to it. Would imagine you need some support there. Your thoughts?
Well, I think this is much like anything else. I think with the integration of data and kind of the cross functionality of the services and what technology can do today, I don't think these are just isolated questions or isolated issues. So this is the job of the CFO, or this is the job of the CIO, or this is kind of nursing or physician focused. I think the technology and the data is now allowing a hospital organization to address the needs of the community as well as provide medical care to patients. So I think it's kind of the joint leadership and the joint decision around where you want to go. So it's the CIO, the CFO, the CNO, the medical directors of the organization working with the folks that address these services, whether it be providing home care, whether it be providing senior or assisted living, or preventive services. I think it's more kind of the group decision and the executive support. So.
All right, very good. Well, that is about all we had time for today. What an excellent discussion and presentation on a very cutting-edge topic that lots of people should be dealing with if they aren't yet. When you close out your WebEx window, you'll be taken to a post-event survey. Please answer that. It won't take you more than a few moments. Regarding continuing education, if you have the CHIME CHCIO certification, attending our webinars gets you 1 credit towards that program's continuing education. And if you're here for another program, you can see the final slide in this deck and use that as proof you attended. You'll receive an email when our archive recording has been posted to our YouTube channel. If you'd like us to produce a webinar on the topic of your choice, you can reach out to Nancy Wilcox. And you can go to our webinars page on our site to view our upcoming schedule of events. So with that, I want to again thank Dr. Shafiq Rab, Toni, Jarrett for speaking. I want to thank Optimum Healthcare IT and Clearsense for sponsoring, and I want to thank you for attending. So everybody have a wonderful day. Thank you.